What made you decide to become a doctor, Dr. DiStefano?
Well, as a child, I was impressed by the work of physicians treating people, and when you get impressed by something like that, you tend to gravitate towards that profession. And so this was during the time of the Depression, and at that time you could get into schools, but you didn't have the money to pay for it. So I had the opportunity to go to a junior college, and then I went to a regular college, and I graduated from Drew University in 1942, at which time I got into the Army as a reserve officer, and then I was accepted at Marquette University School of Medicine, which is now Medical College of Wisconsin. So in 1942, I went to Milwaukee, Wisconsin, to go to medical school with about 10 bucks in my pocket, no place to live, and so it was kind of tough because I didn't have the money, and I tried to get a job, but you can't work and go to medical school. It's impossible. Although nowadays it's a little different, but in those days, about 20% of the class failed, and so you had to really be competitive. But anyway, then of course the war started in 41, but in 1943 got into the Army, and at that time we had what is known as the ASTP, Army Service Training Program, and so I went to basic training in the summer for a couple of weeks in Illinois, Camp Grant, Illinois, and then we went to I went back to medical school, and they made us private first class, and they paid for our tuition and our books, which was great because you didn't have any money anyway. Although tuition at that time was not that much. I think when I first went to medical school, tuition was $500 a year or something. You could get a room for about $7 or $8 a week, and you could get a meal. But for the first month I was there, I had hamburger meal for 40 days, and it was 35 cents. 35 cents, you get a hamburger meal, potatoes, a vegetable, coffee, and dessert, okay? So, but at the time, of course, you didn't have the 35 cents either. So, but when the Army came in, and we were in the active Army, we were Army uniforms, and they paid, I think they paid us something like $150 a month. And they paid our tuition, they bought our books, and the $150 a month was for our room and board and so on. But at that time, we were on an accelerated program. Most medical schools are 4-year programs, but we completed 4 years of medicine in 3 years. So instead of graduating in 1946, we graduated in 1945. And so then when I graduated, I got an internship at Worcester City Hospital. Now, as we graduated, we gave up our private first class ranking in the Army, and we became second lieutenants in the Army Reserve. Now, at that time, also, our internships were 9 months instead of a year. or longer. And so I served an internship at Worcester City Hospital for 9 months. And then on the 14th of June, 1946, I went into the Army as a first lieutenant. And we had a basic training at Fort Sam Houston in Texas. And then after a basic training of, I don't know how long, a month or whatever it was, we were assigned, and I was shipped over to the Philippines. And I spent a year in the Philippines as a medical officer. And then a year later, I was promoted to captain. And after spending a year in the Philippines, I was assigned to a station hospital in Manila, and I was also assigned to I was a medical officer for the counterintelligence group in Manila. And then after a year, my father got sick, and I asked for transfer back to the United States, and I came back to the United States, and I was stationed at Murphy General Hospital in Boston, in Waltham, and I spent a year there, and I was discharged in 1948. Then in '48, I was looking for a residency, and I couldn't find one because everybody was coming out of the service, and they were all pretty well filled. So I spent a year at Hahnemann Hospital as a general resident, and then the following year in '49, I got a residency in Detroit, a surgical residency, and I spent 2 years there. And then I came back to Worcester as a third-year resident at Worcester City Hospital in surgery, and I completed it in July of 1953, and that's when I went into practice, general surgery.
So, you didn't have any debt, right, coming out of medical school?
No, I had just one small debt, about $600, which with the government, and that was paid.
And that didn't affect how you practiced at first?
No, that's right.
Do you feel that physicians today are affected by large debt savings?
Yeah, right. Yeah, because there are a lot of physicians and a lot of students outside of physicians that, a lot of debt because you see, I have a daughter who's a physician. I have a son who's a physician, and my son here is a dentist. So, I remember my son Mark, who does hair transplants now. He was an emergency physician, and his last year at medical school, his tuition was $10,000. No, his 10,000, but then the next year was 20,000. Now you compare what I paid, 500, okay, 20,000. Beyond that, I don't know what it is. It may be higher now. I don't know, but where's the money? And you know that most of the students that go to medical school are not wealthy people. They're average people, and it's a lot of money. I mean, if you're going to go to school for 4 years, and tuition is $20,000 plus, room and board and everything else, so it's not readily available, and you have to borrow, beg, and steal. So I think most students nowadays, do have a problem with having incurred a loan, a debit, which is not, which does tend to put a lot of pressure on them. But the other thing is that students nowadays, doctors nowadays, they don't tend to go into in a private practice like we did. and it was a struggle trying to make a living. Nowadays, they go through their residencies. Now, I went through an internship and a residency, and my internship paid me nothing. My residency paid me $75 a month. Okay, now, are you a medical student?
No.
No. Nowadays, they get a good stipend, so it helps, which they should get, because I mean, they've gone through an awful lot, but in my day, it was a privilege to have an internship, a good,
Yeah.
So it's altogether different nowadays, which is better. In my day, we worked 40. Every other weekend we worked 48 hours on and 48 hours off in the emergency room. Nowadays they just passed a law saying they can't do that. So I mean, those have changed. So I think overall the young doctor, a young graduate doctor, is much better off nowadays than he was in my day. Not only that, but nowadays you get involved in a practice. You join a group, which is very good because you start at a given salary, and malpractice insurance is paid for and everything else, and you get vacations and you get paid for, and you go to seminars, and okay. In my day, you had to go out and try to make a living, and there was a lot of competition. When I first started out, there was Blue Cross, Blue Shield. They paid $50 for an appendectomy. I mean, now I think the price is probably a little different than that. So I think that the doctor is much better off now than he was then.
Okay. So what made you choose Worcester as a place to practice medicine?
Well, I was born in Worcester,
Okay.
and that was the only reason.
No question. Describe a typical day when you first started practicing here.
Well, when we first practiced here, when I first practiced here as a surgeon, we go to the hospital every morning, and we were on service at City Hospital, meaning that we had to give up our time to treat patients that are indigent, that could not afford the thing, and we always on our service we always had 30 or 40 patients that we treated. They were welfare patients, and you treated them, you operated on them, you followed them, you made rounds every day, and with the residents and the interns, and you took care of these patients, and you did it, gratis. Sometimes a patient would come in and have insurance, and you could get the benefit of that, but it was a struggle to try to get a patient, because the doctors that were in practice a long time had the patients, and it was a struggle. So sometimes you covered for a doctor who had been established in his practice, and when he went on vacation for a couple of weeks, you'd cover for him, and you'd get some. But then of course we had our surgical meetings and seminars and so on, and that was it. So when you were on call, you had to be available all hours of the day, night, for emergency surgery, for patients that they were indigent, and you took care of them.
So what were your hours like?
Well, my hours at the time was I'd go to probably get to the hospital about 8 o'clock in the morning, and if I had surgery, I schedule my surgery and do my surgery. If I didn't, I make rounds with the patient, make rounds on the patients that are on service, or my own patients. If I had any patients in the hospital, make rounds with the interns and residents, and teaching and so on. Give seminars and attend surgical meetings, and then in the afternoon I would go to my office probably at 1 o'clock, and if I had any patients to see in my office, I would be there probably from 1 o'clock to 4 4 o'clock.
Okay.
And then go home, and if there were any emergencies, you had a pager, and if any, and that would be a typical day.
Did you ever talk to patients on the telephone?
Oh yeah, yeah.
At any time of night?
Anytime. They'd call anytime, and they'd have some questions. And a lot of them had all day to call, and they never called during the day. They'd call in the middle of the night. So yeah, I talked to them you got to talk to them.
Yeah. So what made you choose your specialty?
I liked surgery. I thought it was exciting. I thought it was challenging. I couldn't. I thought that medicine was, medicine was boring in contrast to surgery. So sometimes, usually a person's personality kind of dictates his specialty.
Right. So did most of your patients come from the Worcester area?
Yeah.
Okay.
Yeah, most of them came from the Worcester area.
Could they choose their physician?
Yes.
Right.
Yeah, they had a right to choose any physician.
How many patients did you have in the hospital at one time?
Oh, when I was I was also on the staff at Doctor's Hospital, and sometimes I would have 10 to 15 patients in the hospital at one time.
Oh, okay. Could you just state again, which hospital did you work at here in Worcester when you started?
I worked at City Hospital,
Right.
Fair Lawn Hospital, Doctor's Hospital, and when I first started, I did some work at State Hospital. Just the matter, I think they paid $50 for an operation, any kind of operation, but just to keep your hands in the pot. Better to do an operation than do nothing.
So, when you started practicing, what made you decide to keep being a doctor? What did you really like about it?
It was challenging. Challenging. It was never the same. You're helping people. It was dramatic. Surgery was dramatic. I mean, you get an acute appendicitis, you get pain, and you take it out, and the patient is better. I just didn't feel I wanted to treat people for a chronic problem like heart problem, or it was, to me, it was boring. But surgery was more exciting.
Yeah. What do you think it was like for your family to have a physician in the household?
Oh, well, I think they were impressed because three of my 4 children are in medicine. So I think that they. I never talked them into it. They did it out of their own volition. So they must have been impressed by my type of work.
Okay. Did you have vacations?
Yeah, I don't have. Yeah, I would take a few weeks off a year, something,
Okay. Right. So what were the typical illnesses that you dealt with in the 50s, 60s? I mean, what kind of surgeries did you do?
Well, as you know, this was not surgery, but around the late 40s and 50s, there was still polio, and that was a big thing. And there'd be epidemics of polio. But of course, with the Salk vaccine, that disappeared. So I dealt with primarily surgical problems, and my surgery was usually abdominal surgery, so it dealt with bowel, stomach, appendix, gallbladder, female problems, and mostly general surgical problems.
Okay. And it's always been that way? Has it changed at all?
Well, I don't do surgery anymore now.
Right.
I retired from surgery in 1986. So what I do now, I just see I'm just in the office one day a week, and I see probably 10 to 15, 20 patients each time, and that's it. So, but you know, medicine has changed a lot during the years.
Of course, yeah. What was the greatest challenge for you when you started practicing? I guess what kind of surgery?
Was what?
The greatest challenge for you?
Well, the greatest challenge, of course, was trying to get patients. You know, because because you get out of a residency where you're operating all day long, and then you get into private practice and there's nothing there. You know what I mean? And so you got to struggle to get a patient, and so that was the biggest challenge. But some of the problems that were present then, like, for example, we did surgery for peptic ulcers. Well, you don't see that anymore now because now it's all treated medically. So some of the problems that were present when I first started are no longer present. But I mean, there are different problems now. Okay.
Yeah.
Different specialties have become more prominent. You know, like there was never any cardiac surgery. Now there's cardiac surgery. There's vascular surgery. When I started, there was very little vascular surgery. Vascular surgery became developed actually during the Korean War. That's when they started to do repairs of arteries that from trauma, war trauma, and then that's where vascular surgery developed, and then from there, of course, then you had bypass surgery, coronary surgery, and all the other aneurysms and peripheral vascular surgery. You know, so they gradually developed.
What have you seen as one of the most important breakthroughs in disease treatment throughout the course of your career in medicine?
No, I think probably antibiotics, as far as the treating infections. Those came. Penicillin started probably during World War II. When I was in medical school, that's when they first used penicillin. Fleming. At that time, the dosage was I think 15,000 units. Then, of course, they upped the dosage, and the other thing is with penicillin, you get rid of gonorrhea, venereal diseases, syphilis. So that was a very important change. The Salk vaccine got rid of polio. The other type of vaccinations get rid of smallpox. Okay. So those were changes, probably started a little before my time and have continued. And then some of the surgical problems responded to medical treatment. And some of the medical treatments responded to surgical treatment, right? I mean, you get coronary artery disease, that patients had a heart attack, and you put them on medicine, medicine, and they went into heart failure and things like that. But now, surgery, with the coronary bypass and stent, angioplasty, that's sort of a surgical type of problem that's corrected by surgery. So that some of the medical problems became surgical, and some of the surgical problems became medical. All right? Yeah.
Okay. What is something that doctors take for granted now that you didn't have in your career, like in terms of technology?
Oh, technology is altogether different. I mean, we had, when I was a medical student, and even after, it was a challenge to make a diagnosis. And we would, and a patient came, let's say a patient came in with a pain in the stomach, and you had to clinically examine the patient and evaluate him and make a diagnosis. And it was challenging because it tested your acumen to put everything together and arrive at a diagnosis. And you did not know what the diagnosis was many times until after the surgery. All right? Nowadays, it's all there for you. Nowadays, every operation is no longer a question mark. You know exactly what you're going to do. I mean, MRIs, CAT scans, every other thing, it's right there. So you go in and you operate, because you know what you're operating for. Years ago, it was a challenge. Well, not a challenge, but you tested your ability against another doctor. Okay, so you have say we had a surgical meeting, a seminar, and they bring up a case of this patient having a problem, abdominal pain, we'll say. So you discussed it, and you'd say, well, I think this patient has, we'll say, an acute appendicitis or whatever. Another doctor would say, well, I think it's something else. So it would be sort of a competition between one doctor and another, okay, which was good. Nowadays, I mean, everything is there. The other thing, of course, is that nowadays you have laparoscopic.
Yeah.
Okay, that a lot of these operations are done by laparoscope. It's like running in a Nintendo game, right? You look to there and you're maneuvering the thing. My grandson, 7 years old, and he maneuvers those damn thing this way and that way and upside down. He has about 300 different cartridges and Mario and whatever it is. Well, that's what laparoscopic is. He looked through the screen, and you see and you manipulate. So in my days, we don't have that. You made a big incision, and you got to the root of the problem. The bigger the incision, the better you could see what you were doing. Nowadays, so it's a different altogether. Okay, nowadays they're doing gallbladders, appendices, hysterectomies, kidneys, everything through a laparoscope. That's another big thing. Okay, so it means that there's a shorter period of convalescence because there's less invasion, and it's important because then instead of spending a week in a hospital at maybe $1,000 a day, you're spending nothing, a day maybe, okay, and it saves a lot of money. So
you found that a lot of surgery when you started practicing or back in the 60s was not only to treat the patient's problem, but to actually find out what the problem was.
Yeah, I mean, you had no choice. A patient, a patient had the problem, and you couldn't, sometimes a chronic appendicitis, the patient would have problems, and not acute, but a chronic. It bothers them, here and there, all right? And, or a female that has some problems, and female problems, okay, a ruptured an ovary or something. So the patient complains of problems. So you have no choice but to go in and operate. Nowadays, of course, you can put a laparoscope in there and take a look inside and see what's going on. So it has advanced, and it's all for the good. It's all for the good. Because he did not really want any unnecessary surgery, because every time you have surgery, there's always a risk. It may be minimal, but again, when you undergo anesthesia, and there's always a risk.
So what technology did you have in the 50s and 60s for diagnosis? Is there any technology you had that's still used today?
That what?
That doctors still use today? Is there any technology?
X-ray. A plain X-ray.
But it was a lot more complicated, like to develop, right?
Yeah, well, you couldn't see much. I mean, if you wanted, if a patient had abdominal pain, you could get an X-ray of the abdomen and look, see if they had a ruptured ulcer, if they had a ruptured bowel, and you could see the gas, you know. But it was, you know, it was a very simple thing, and it would give you very little knowledge. You know, only in certain conditions it may give you some knowledge. I mean, nowadays you get an MRI or a CAT scan, and there's sections, and you know, and it shows the difference and from normal to abnormal, and you can pick anything up. So, and at that time you had, you know, your blood count was about the same as it is now. And you had, and of course, and you have other tests, you know, liver function tests and kidney function tests and things like that. As far as the chest was concerned, an X-ray of the chest was pretty conclusive. You know, you could tell if there was a tumor in the lung, or, you know. So, but as far as the abdomen was concerned, it helped a little bit, but not a lot. But you know, orthopedics, and it was a different situation because that was bone.
Did you always have access to the new technology in your field as it became invented?
Yeah,
Okay.
yeah, because you always, you know, because as this technology became invented, it was used more and more, and it was something that you could no longer be without. So that, you know, I remember the MRI when it first came out. They only could afford one MRI, you know, and all the doctors. Now you have, I think they have two in the city of Worcester. I don't know, they probably have some, but you know, so even in the small, remote areas, you know, you didn't have an MRI. Now, MRIs are all over the place. Small hospitals, big hospitals, and so it's just part of medicine.
Is there anything that you'd like to see invented in medicine, in your field, or generally in medicine, any piece of technology?
I think the thing that probably is going to be good, that I'm sure they're going to invent it, is the growth of organs. In other words, getting cells and growing livers or kidneys or whatever, heart for transplant.
Yeah.
I mean, I think that's going to be the biggest thing.
Yeah.
And that will come soon, because instead of putting in a mechanical heart or getting a heart that may be rejected, and you're going to have to take medications to stop the rejection, they grow your own. So however that's going to work out, I don't know,
Sure,
but
that'll come soon.
yeah.
Could you briefly describe attitudes towards smoking and cancer throughout your career in medicine?
Does what?
Smoking and cancer.
Oh, well, I mean, it's definitely proven that smoking causes cancer of the lung. If it doesn't cause cancer of the lung, it causes emphysema, and they're both bad. It's a very bad irritant. You know, it's a carcinogenic drug. I smoked, and I gave it up in 1954, and I think it done me a lot of good. And you know, smoking not only your lung, but also it affects your heart.
Yeah.
Nicotine, so blood pressure and heart and so on, hardening the arteries. So it's no good.
Okay. So, do you think that everyone who needed health care received it back in the 50s and 60s?
No, never, no.
Okay.
No, you know, well, okay, let me put it this way. They did as welfare patients, as indigent patients, okay? So because we had hospital, like City Hospital, that was run by the city, And if you had no insurance or no means of paying for it, you'd go to the emergency room and they would admit you. For example, City Hospital had, when I was a resident there, 30% of all the patients in the hospital were non-paying patients. They were paid, they were there at the city supported them, okay? So the city supported the hospital. So if there was a deficit, they'd make it up. So about 30% of it was charity work. 70% was private. And some hospitals, of course, were 100%, maybe not. But, there's a lot of big hospitals like Boston City Hospital, Bellevue Hospital, Kings County Hospital, and all these big hospitals, Los Angeles, and they were all charity patients. So that all changed now.
How do you think Worcester has compared to other places over the years in terms of providing care for the underserved?
I think Worcester's right up there. They did a good job. Patients get the benefit of the outpatient department. We were assigned. We were young when we were assigned to the outpatient department, and I would go once a week in the outpatient and take care of patients, same as I would in my office, and then I would give my time to teaching. I give my time to taking care of surgical patients. So patient was never turned down. So the patients got their treatments.
What were some fears and concerns about socialized medicine in the 50s and 60s?
Oh, there was socialized medicine was the fact that they were afraid, number one, that patients would not get the proper care, and that they sort of compared it to the way it was in England and Canada, where patients had to wait for their surgeries and things like that, and that the doctors would be overrun with patients, and they would not get the full amount for their work. So those were the main problems, that people could not get the same one-on-one contact with the doctor that they didn't always get to the doctor they wanted. They would get another doctor, things like that. So it was.
Okay. As managed care came into medicine, with Medicare and Medicaid in the 60s.
Yeah, the HMOs came in.
Yeah. How did you see physicians and patients and generally people's access to health care each be affected?
Well, they were affected because health care was like a business, a money-making proposition. They had to make they had to make money, and I think the personal relationship between doctor and patient was gone. If you got to a big HMO, you never got to the doctor you wanted to go to. You get to whoever was not busy, and patients took advantage of the situation. They went to doctors more often than they should have gone, and the doctors were overloaded, and so they did not spend as much time with the patient as a private doctor would. You did not know. The doctors never got involved in the other aspects of a doctor-patient relationship, the family, and when you have a private practice, and you treat a patient, you know about their husband, wives, children, and all these things. You act as not only a doctor, but as as a psychologist and everything else, okay? So, and a lot of that went by the wayside with HMOs. So because and not only that, but then the HMOs had to pay, if there was a question about going into a hospital, they would tend to, I think they would be on the conservative side because it cost them money. You know, they would have to pay a hospital for the room. And so it was a lot cheaper to not have a patient in a hospital if they didn't have to. So with a private doctor and private insurance, if there's a question, you send them to the hospital and take care of them. There you say, well, you know, maybe we'll wait a while, do something. So it tended to disrupt the patient-doctor relationship.
So, how have you seen people's access to care be affected in a positive or negative way?
What HMOs?
By HMOs, managed care, Medicare.
Negative way. Patients, I don't think patients as a whole like it. They accept it because they have to, but I don't think I think patients like the close relationship between doctors and patients. You can go talk to your doctor about anything you want. When you go to an HMO, if you don't get the same doctor that you always had, you don't want to talk to him. You don't feel free to talk to him about other things. So it sort of disrupts the whole relationship because it's more like a business type of thing.
Yeah. What would you like to see happen with government and healthcare?
I like to see it happen that patients can choose their own doctor anytime and have their own doctor. You know, because I think that makes for good medicine, and it makes for patients wide open, and they tell you exactly what they want to tell you because they have complete confidence in you, and you know, they don't feel embarrassed about saying certain things, and that's the way it should be. Doctors should know completely everything about the patient.
We're going to move on now. Could you tell me how doctors' salaries have changed over the course of your practice?
Oh, I'm sure they've gone up, you know, a lot.
Managed care, of course, right?
Well, I don't know how they work in managed care because I never had anything to do with them, but they're on a salary, so I think that being on a salary serves two purposes. One, it limits the amount of money you can earn. But you're earning money and you don't have to worry about you know, starting out. So it's good when you start out because you'll get a salary, you have somebody to cover for you, you go to seminars, you know, vacations, everything else. It's good. But in private practice, I think that you probably can make you can make more money. And of course, some people in private practice make less money because they don't get along. I don't know, but I think it's a good startup, and I think that's the way of medicine. And I think that probably that's a better way because I think that it's no longer a struggle. You know, I think doctors work all hours of the night. You know, calls and everything else, and now they work. They know exactly what they're going to make, and they know and. There's no worry about where the money's going to come from, and they can plan, you know, on the money that they earn. So, in most cases, I would say it's good.
Where was most of your income from in the early part of your career, being a private practice?
Just surgery.
How has malpractice insurance, as well as its impact on doctors' practices, changed over the years?
Oh, malpractice insurance was almost nothing. And then I remember in the 80s when I quit, one of the reasons I gave up surgery was because of malpractice insurance. It was, you know, $50,000. It cost, and at that time, of course, the city hospital was closing, doctor's hospital was closing, and probably it was more to pay. My malpractice insurance cost me more than I was making, and because then you started to get a lot of malpractice suits. You know, like everything else. You know, it just it just gets more and more. You know, and so malpractice. Some of the obstetricians were paying $100,000 or more for malpractice insurance. Orthopedic surgeons, you know. So it now I work 1 day a week, and I don't have any hospital practice, and it costs me almost $3,000 a year for malpractice. So, but some of the vascular surgeons, and I'm sure they pay 40, 50,000. So it's you know, it's appreciated a hell of a lot more than the earnings or the wages. You know, it got out of whack. I mean, it got out of whack there in the 80s. But I don't know what it is now because I don't do surgery, so.
And you think it's affecting the medical practice more than it should be?
Oh yeah, I mean, of course. I mean, you know, whenever you have malpractice and you know, and you're afraid people are going to sue you, yeah, it does affect you, you know. And then, you know, you know, you just can't take anything for granted. You know, it's good because it makes you a little more vigilant. You know, you don't. I mean, you're careful how you know that you don't. But a lot of these cases, you didn't have to. It was no longer negligence. It was not negligence. It was what the results were. So a doctor could be very conscientious, but not get the results that he should get, and he'd be sued for negligence. And it was never negligence. I mean, you know. So malpractice became a widespread type of condition, okay, and as that happened, then of course the malpractice premiums went up, and they went up, you know, from a few $1,000s to $50,000, $75,000, $100,000, you know. They get completely out of control.
Okay. How did you learn the business of medicine, if you ever learned it, really?
Trial and error, you know. There's nobody came in and tells you, no, this. I suppose there were probably some books or seminars, you know, but there's mostly trial and error.
Do you think that's something maybe medical students today should maybe be taught a little more about? I mean, not.
Well, I think nowadays, no, because I think nowadays they work for maintenance organizations or whatever, and that's all taken care of.
Okay.
I think that if you're in your private practice, yeah, I think they should, you know, they should learn the business of charging, collection, retirement, and all that business.
Moving on to the Worcester community now, what are some changes that you've seen in the demographics around here in Worcester?
Nothing's changed.
Okay.
Nothing's really changed. You know, I was born in Worcester, lived in Worcester, and the demographics have not really changed. The population of Worcester when I was about 170,000. It's still the same. I think what happened is maybe some of the people moved to the suburbs, you know. And Worcester is a small it's a provincial city. It's the second largest city in New England, but it behaves like a small town. I mean, Providence is smaller than Worcester, but I think Providence is more progressive, and so is Hartford, so is Springfield. So Worcester has been kept back by a certain number of families in Worcester, like the Higgins and the who else? The Stoddards and the you know, Nortons and so on, and they, you know, and they kept it. Even, you know, even when I started out,